So I recently changed my systems and I had to get a bit used to the new system that I was adopting. So that's why I haven't been really releasing any videos. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazebu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at the use of oxytocin in the labor ward. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper and let's go. So remember that oxytocin is just a nonapeptide, meaning it's consisting of 9 amino acids that's going to be synthesized in the hypothalamus, predominantly in the supraoptic and paraventricular nuclei. It's going to be transported along these axons and it's going to be released from the posterior pituitary gland. And remember that oxytocin and ADH, antidiuretic hormone, also referred to as vasopressin, are going to be released from the posterior pituitary gland. This is very important because when you look at the chemical structure of ADH and you look at the chemical structure of oxytocin, they have similarities and only differ in about 2 amino acids. So remember that at higher doses of oxytocin, you can actually have vasopressor effects as well as ADH effects. Functions of oxytocin. Generally, you remember that oxytocin has a half-life of about 3 to 4 minutes and an approximate duration of action of about 20 minutes. And once it has been in the system, it's going to be rapidly metabolized and broken down by the enzyme oxytocinase. And eventually, remember that during labor, the number of oxytocin receptors that are present on the uterus tends to increase to the maximum. So they increase by about 100 to 200 fold. The mode of action of oxytocin is that it's going to be binding to these oxytocin myometrial receptors and it's going to be stimulating the voltage-gated calcium channels. And remember, an influx of calcium into the intracellular compartment is going to stimulate these myometrial contractions. It's going to also stimulate amniotic as well as decidual prostaglandin production, and the bound intracellular calcium is actually going to be mobilized from the sarcoplasmic reticulum to activate the contractile proteins, and the uterine contractions are going to be physiological, meaning that they're going to be causing the fundus to contract without relaxation of the cervix. Now, oxytocin is going to cause stimulation of the uterine muscles, and remember that in the first trimester the uterus doesn't have so many oxytocin receptors, so the uterus is not going to respond to oxytocin, so it's kind of refractory to oxytocin. Though in the second trimester there is a relative refractoriness and such, you can use oxytocin as an agent for abortions to induce abortions together with other agents. Then as you go further in later in the months of pregnancy and during labor, it's actually the uterus becomes very sensitive to oxytocin, and even just such that small doses can actually cause a lot of contractions in the uterus. Remember that oxytocin loses its effectiveness unless if it's preserved at a correct temperature that's between 2 to 8 degrees. Another function of oxytocin is that it causes contraction of the myoepithelial cells, and this is going to lead to ejection of milk. It also causes a bonding between the mother and the baby, and this is one of the reasons why we actually encourage women to start breastfeeding early, as this stimulates the release of oxytocin. Remember, it also functions in the contractions of the vas deferens in men during the process of ejaculation. So what are some of the indications that we need to know in relation to the use of oxytocin? So it is used during pregnancy. Early on in pregnancy, it can accelerate abortion. For example, in a patient with an inevitable or a missed, or sometimes even if you want to expedite the expulsion of a high for mole, a molar pregnancy. It also is used to stop the bleeding after you evacuate the uterus, maybe after an incomplete abortion or maybe after an inevitable abortion. It's used to adjust as an adjunct rather to induction of labor along these other abortifacient agents such as the prostaglandin E1 and the prostaglandin E2. Later on in pregnancy, it can be used for the induction of labor, augmentation of labor, in the treatment of postpartum hemorrhage, as well as the prevention of postpartum hemorrhage, especially in individuals with high parity, and also in the active management of the third stage of labor. In the puerperium, it's used to minimize blood loss and to control the postpartum hemorrhage. Some diagnostic indications include during a contraction stress test, which we'll talk about in another video, as well as during an oxytocin sensitivity test. Contraindications of use of oxytocin include during pregnancy in grand multiparity, that's someone who's had more than 5 pregnancies carried past the age of viability, in someone with a contracted pelvis, in someone with a history of cesarean section or hysterotomy, someone with malpresentation, during labor, anyone with any of the above contraindications, or if they have an obstructed labor, or if they have incoordinated uterine contractions or fetal distress, which is manifested by a drop in the fetal heart rate. You could have presence of molding, you could have caput that may form, you may even have the child passing meconium, fresh meconium. Then of course, at any time if they are hypovolemic or have a cardiac disease, oxytocin is relatively contraindicated. So what's the dosing that you need to remember? So remember, if you are doing the active management of the third stage of labor, you can give it either as intramuscular or intravenous. So if you're giving it, it's intramuscular, you give it over the thigh, you give 10 international units, that's about it. But remember, you can also give it as an intravascular injection. And once it's given at this, there are 2 prerequisites that you really need to know. Number 1, you have to give a lower dose. So it means instead of you giving the 10 international units, you're going to be giving the 5 international units. Number 2, you're going to give this slowly, because if you give it so quickly, it may actually cause hypotension. Remember that oxytocin has similar features to ADH. So this dose is actually going to be given in abortions after evacuation. We can give them the 10 international units as an IM over the thigh to help the uterus with the contraction. It can also be used for induction of labor, where we start off at 1 to 2 million international units per minute up until we reach 8 million international units per minute. But in our setting, we actually start at a slightly higher dose. We start at 2.5 million international units of oxytocin to about 20 million international units per minute of oxytocin. That's our maximum dose. And you want to keep increasing the dose. You want to keep doubling the dose until you get an appropriate response. And what is this appropriate response? If you have 3 moderate contractions every 10 minutes, and once you get this response, you continue them on this infusion. This is what we call is oxytocin titration. Then you can also use it for augmentation of labor with similar doses, 2.5 million international units per minute with a maximum of 20 million international units per minute. In PPH prophylaxis, we give slightly higher doses. So we give 20 million international units per minute up to 60 million international units per minute. If you don't understand what this million international units per minute is, I will explain it very shortly in the next slide. So remember that this is going to be given until you have the sufficient contraction to stop the bleeding, and similar doses can actually be used in the evacuation of a molar pregnancy. Remember that the total dose that you should give a patient should not exceed 30 to 40 international units in 24 hours, because oxytocin has some side effects on the mother. It also has some side effects on the fetus. Now, how do you make the dilution? So what you need to remember is that the synthetic oxytocin or syntocinon is pretty much commonly found in 2 main formulations. So you're going to be having a vial that's going to be containing 5 international units of oxytocin in 1 ml, or 10 international units of oxytocin in 1 ml. In our setting, we usually have the ones that are going to be having the 10 international units per ml. So it means if you give 1 ml of that ampule, of that vial, it's going to give you 10 international units of oxytocin. There are some formulations that contain a combination of syntocinon 5 units and egometrin 0.5 milligrams, which we call syntometrin, though these are not found in our wards. And remember, anything with egometrin should be avoided, especially in hypertensive patients. So, before you actually determine the dose of oxytocin in million international units, there are 3 things that you must know. The first thing is you must know your infusion rate of your giving set. So there are different types of giving sets. You have the macro giving sets, you have the micro drip giving sets. The ones in pediatrics can even give you as much as 60 drops per minute. Then the ones that we're going to be using in our labor ward commonly are the ones that are going to be giving you 20 drops per minute to give you 1 ml. And then of course you may also have 15 drops per minute to give you 1 ml. So ensure that you check on your giving set to see how many drops per minute will give you 1 ml from that giving set. So that's the first information that you really need to know. The second information is how much oxytocin you're actually going to be injecting into the vial. So for example, rather into the fluids. For example, if you have 10 international units in 1 ml, so it means you're going to have 10,000 million international units, because remember that we want to use the million international units because it gives us a much accurate dosing as compared to actually just giving the international units as just they are. So we can actually titrate it to almost a very, very accurate way, because in our setting we don't have these infusion pumps. So remember that 1 international units is going to be equals to 1,000 milli international units. So if you have 10 international units, that's going to be equivalent to 10,000 milli international units. If you have 5 international units, this is going to be equivalent to 5,000 milli international units. So remember, 1 ampule of oxytocin is going to be about 1 mil. So it means that in 1 mil, if you have 5 international units, you're going to be having 5,000 milli international units. In 1 mil, if you have 10 international units, you're going to be having 10,000 international units. The second thing is the volume of fluid that you're going to be placing this oxytocin in. So generally, we use 500 mils for those patients that are what we call high risk. If there's a risk of edema, if there's have cardiac disease, if they have renal disease, we want to use less fluid because we don't want to overload them. In other patients, you can use as high as 1 liter of either normal saline, which is the ideal solution, or Ringer's lactate. So here's an example. So suppose we get 2.5 international units of oxytocin. So what does that mean? So if we have a 10 international units vial, it means we're going to be getting 0.5 mils of that solution. How do I find this? If 1 mil is equals to 10 international units, how much will 2.5 give you? Say x. So 1 to 10 and then 2.5 to x multiplied by 10, 1 multiplied by 2.5. Then, of course, to find x, you're going to be dividing that by 10. So 2.5 divided by 10 will give you 0.25. So it means if you have a 10 international unit of oxytocin, you're going to be getting 0.25 mils of that solution. If you have one that has 5 international units per mil, you're going to be getting 0.5 mils of that solution. Then once you get this, remember both these solutions are going to be consisting of 2.5 international units of oxytocin. Remember that once you get this, you're going to be placing this in 1 liter of IV fluids, be it normal saline or be it Ringer's lactate. So what have you created? Remember, 1 international unit is equals to 1,000 milli international units. So 2.5 international units is going to give you 2,500 milli international units of oxytocin. So it means in that 1 liter of oxytocin, you have 2,500 milli international units of oxytocin. So remember, this is going to translate to a concentration of 2,500 milli international units per mil. And if you actually want to reduce this, you divide both sides by 1,000. So it means in 1 mil of that solution, you're going to be giving 2.5 milli international units per mil. So, but remember, how do we get 1 mil? Remember that 1 mil is going to be gotten from pretty much giving our 20 drops per minute, but I'm going to come to that. So let me give you another example. Suppose we want to now get 5 international units of oxytocin. So if we get 5 international units of oxytocin, it means that we're going to get 0.5 mils of the 10 international units per mil, because you want 5 international units, so it's pretty much half of this ampule. Then of course, if you have one that has 1 mil is equals to 5 international units, we can get the whole meal. If we get this fluid, which is the 5 international units of oxytocin, and we place it in 1 liter of IV fluid, it means that we're going to be having 5,000 mils per international unit per 1,000 mils. And if we reduce this by divided by 1,000 on both sides, we're going to be having 5 milli international units in 1 mil per solution. So this is how you come up with the concentrations if you really want to come up with these concentrations. But because remember that these concentrations are going to be guiding you on pretty much how you're going to be running the drops, such that you can deliver the adequate amounts of oxytocin. So remember that in PPH, we're going to be using 20 international units of oxytocin in 1 liter of either normal saline or Ringer's lactate. So it means if we're getting that 20 international units, that's going to translate to 20,000 international units per 1 liter, per 1,000 mils. If we want to reduce that to million international units, we divide both sides by 1,000. So it's going to give you a final concentration of 20 milli international units per mil. So that's our concentration of the fluid that we have created. But remember the giving sets that we're having. 20 drops is going to be giving you 1 mil. So in 1 minute, you're going to be giving 20 drops, and this is going to be equals to 1 mil. But remember, how much is 1 mil going to be giving you of this solution that you have created? 1 mil of the solution gives you this 20 milli international units. So therefore, we can say that for us to give the 20 milli international units per minute, we should let it run at 20 drops per minute. So it means you're going to be, the instructions that we're going to give this patient is that we get 20 international, or the nurse or whoever is attending to the patient, we get 20 international units of oxytocin. We're going to be adding it to 1 liter of fluid, and we're going to start off at 20 drops per minute, and then we can double that. So remember, if we double that to 40 drops per minute, it means we're now going to be giving double the concentration. So we're going to be giving 40 milli international units per minute. So what about when we're augmenting labor? Remember, we are going to be starting at a dose of 2.5 milli international units. Even with induction of labor, we may start with lower doses of 1 to 2 milli international units per minute. So what we're doing, let me give you possible scenarios here. Suppose we get 5 international units of oxytocin and we add it to 1 liter of fluid. So it means you have 5,000 milli international units in 1,000 mils of fluid. If we reduce that even further, our concentration of our fluid is going to be 5 milli international units per mil. But remember, 20 drops per minute is going to be giving you 1 mil. So it means that 1 mil, in 1 mil, you're giving 5 mils, milli international units. So it means because of this concentration, 1 mil is going to be giving you 5 milli international units. So in essence, what we're saying is that this 20 drops that we're giving is going to be equivalent to 5 milli international units per minute. But remember that we want to give half this dose. We want to give, instead of us giving 5 milli international units per minute, we want to give 2.5 milli international units per minute. So we're going to be dividing the drop factor by 2. So we divide both sides by 2. So it means that for us to get 2.5 milli international units per minute, it means we should give it at 10 drops per minute. So it means if you get the 5 international units of oxytocin and you add it to 1 liter of fluid, it means the instruction that you're going to give is that you want to start it at 10 drops per minute, and then we double the dose, we double the drop rate at 30-minute intervals. And remember, we should reach a maximum of 20 milli international units. Then if you now get a 5 international units and a 500 mils of fluid, which is what we commonly use in our setting, suppose we get 5 international units of oxytocin, meaning it's 0.5, half of that vial that you have in the labor ward that has the 10 international units per mil. So half of that added to 500 mils of the normal saline, or you add it to 500 mils of the Ringer's lactate, it means that you're going to have 5,000 milli international units in 500 mils of normal saline, or 500 mils of Ringer's lactate. If we reduce that concentration even further by dividing by 500 on both sides, we're going to be remaining with 10 milli international units to give you 1 mil of solution. But remember, each of those given sets is going to be giving you 20 drops per minute. So in essence, our 20 drops per minute is going to be giving us 10 milli international units per minute. But remember, we want to start to give at 2.5. So we want to reduce this 10 by 2.5. So we simply divide this by 4. So if we divide both sides by 4, we're going to get 2.5 milli international units per minute is going to be, meaning that we translate that to give 5 drops per minute. So this is the common regimen that we use during the induction as well as the augmentation of labor. Remember that when we're doubling the dose, we are going to increase the drop rate. And so we're going to increase from 5 drops per minute to 10 drops per minute to 20 drops per minute to 40 drops per minute. So the maximum that you're giving should be 20 milli international units. So it means it should translate to 40 drops per minute when you have added 5 international units to the 500 mils of the normal saline or the Ringer's lactate. I hope that makes sense. So in patients that have cardiac disease, we can actually even give them small concentrations of or small amounts of fluid rather than diluting the oxytocin in larger volumes of fluid, because we don't want to overload them. So in these patients with heart disease and patients with preeclampsia, we're often going to take 10 international units and add it to 500 mils of fluid. So this is going to reduce to a concentration of 20 milli international units per minute. And remember, if it's running at 20 drops per minute, it means that this is going to be giving you 20 milli international units per minute. So when you augment it, you can actually start it at 2.5 drops per minute if you're able to calculate that, or you can actually start it at 5 drops per minute, which would be at a higher dose. So remember, the order that we're going to give is, when we're augmenting the labor, 5 international units in 500 mils of fluid to run at 5 drops per minute. Then we double the dose every 30 minutes to a maximum of 40 drops per minute. I hope that makes sense. So here's a table to just simply show you of the oxytocin that you're adding to the 500 mils of Ringer's lactate, and of course the milli international units that you are giving if the giving set is giving you 15 drops per mil as opposed to the one that has 20 drops per mil. So take your time to actually look at these tables. It's very easy and self-explanatory. So remember that oxytocin has certain side effects. Some of them are maternal side effects, which include uterine hyperstimulation, which could be either polycystole, where you have more than 5 contractions in 10 minutes, or you can have a contraction that's lasting longer than 60 seconds. We call that as hypertonia, which is often associated with fetal distress, where you get this abnormal fetal heart tracing. Then when you actually notice that this person has uterine hyperstimulation, what are you going to do? You often want to stop the oxytocin infusion. Remember, oxytocin has a short half-life, so it means that you want to monitor these patients frequently. So you want to monitor the fetal heart, and of course you're going to be using your CTG. Or you can use your PNOD, where you actually listen to the fetal heart every 5 minutes for 30 minutes. If the fetal heart actually comes to normal, we reduce the dose to half the dose of what we're giving that caused the fetal distress. But in most of the cases, we actually do take the patient to cesarean section and they get a C-section. Oxytocin may also cause uterine rupture, especially with these violent contractions, and high-risk patients are going to be patients like grand multiparity, malpresentation, contracted pelvis, prior uterine scar, for example, hysterotomy, as well as excessive use of oxytocin. It may also result in hypotension, especially if it's given intravenously and it's given very quickly, especially in patients with a background of hypovolemia or with a heart disease. Remember, occasionally oxytocin can also produce anginal pain. At higher doses, that's about 30 to 40 millinternational units per minute, which is a high dose. If you give it with a lot of IV fluids or fluids that have dextrose in it, this can actually cause an individual to actually develop brain edema, and this can actually lead to death. Oxytocin or water intoxication caused by oxytocin will be manifested by hyponatremia, confusion, coma, convulsions, congestive heart failure, and even death in extreme cases. You can actually prevent this by having a strict input-output chart. You can actually use a salt solution, and you should avoid high doses of oxytocin for a very long time. Oxytocin at high doses also has an antidiuretic effect, so at doses of 40 to 50 millinternational units per minute and continued for a long time, you could have an antidiuretic effect. On the fetal side, it does cause fetal distress, so the fetal hypoxia or even fetal death can actually occur, especially with uterine hyperstimulation. And remember, uterine hypertonia or polycystole does actually reduce the placental blood flow. For the induction of labor using oxytocin, we want to pretty much start at a low dose, and then we escalate it at intervals of 20 to 30 minutes where there is no response. And when you get this optimal response, meaning when you get these uterine contractions that are lasting about 45 seconds, meaning they're moderate contractions, or you have 3 of them in 10 minutes, or plus 3 of them in 10 minutes, then the administration of oxytocin is actually continued at that particular rate. Like I said, that's the oxytocin titration technique. So the objective of this is that it's not only to get this effective uterine contractions, but it also is to maintain this pattern of uterine activity until the person delivers, or at least even 30 to 60 minutes after they deliver. And remember that the infusion dose is going to be expressed in millinternational units per minute, so you can actually have an idea of how much oxytocin exactly you're giving to this patient, regardless of the concentration of the solution that you have. So what regimen are we going to use? We start off at a low dose, 1 to 2 millinternational units per minute, and we escalate by 1 to 2 millinternational units per minute every 20 minutes to a maximum of 8 millinternational units per minute. But in our case, we can actually start off 2.5 millinternational units per minute. So we actually give 5 international units of oxytocin in 500 mils of normal saline or Ringer's lactate at 5 drops per minute. So that's about 2.5 millinternational units per minute. That's our concentration. Then of course we double it every 30 minutes to a maximum of 40 drops per minute, which means that you're going to be giving a concentration of 20 millinternational units per minute. Remember, the patient must be laying on their side, on one side, or in the semifowler's position to prevent this veno-cavo compression syndrome. And then with the higher doses that begin with 4 millinternational units, and then we increase by 4 millinternational units per minute at 20 to 30 minute intervals. These ones are mainly used for augmentation of labor and active management of labor, and there is a risk of hyperstimulation of the uterus. There is a risk of fetal distress. There is a risk of heart irregularities, especially with these higher doses. Remember, in the majority of the cases, a dose of less than 16 millinternational units, that's about 2 international units or 500 mils of Ringer's lactate, to be dropping at 60 drops per minute is enough actually to achieve the objective. Then of course the conditions where you have this fluid overload should be, you should avoid a lot of fluids, so you should actually infuse them with high concentration, but you should reduce the drop rate as we already talked about earlier on. For the augmentation of labor, remember oxytocin is used in the labor ward, especially when there's uterine inertia, or for the augmentation of labor in the active management of the third stage of labor. So the procedure actually is going to be consisting of low rupture of the membranes followed by this oxytocin infusion when the liquor is clear. You must make sure that you rule out any fetal pelvic disproportion before you actually administer the oxytocin. So what observations do you want to do in a patient who is in labor? So you want to check the rate of flow by actually counting the drops per minute for a full minute, or you actually want to monitor the infusion pump. Then for the uterine contractions, you can actually number the contractions per 10 minutes and the duration of the contractions, and the period of relaxation should also be noted. If you don't have enough gadgets to do this, you can actually do a fingertip palpation of the tone of the uterus in between the contractions, and I'll show you actually how it's done on the next slide. Then the peak intrauterine pressure should be about 50 to 60 millimeters of mercury when the uterus is contracting, and with a resting tone of 10 to 15 international units when the uterus is not contracting. So this is what we consider as optimal. You should also have this fetal heart monitoring with this continuous electronic fetal monitoring, or you can auscultate the fetal heart every 15 minutes. Remember, you should also assess the progress of labor. You should actually check for the descent of the head. You should also check for the rate of cervical dilatation. So this is the finger tip palpation to actually check the tone of the uterus when the uterus is actually relaxing. So what are some of the indications to stop the infusion? So if you get abnormal nature of the uterine contractions, so if they are very frequent, every 2 minutes or less, or if they're lasting more than 60 seconds, meaning that there's hyperstimulation, or if they are more than 5 and 10 minutes where there is polycystole. If there's an increase in tone in between the contractions, you want to stop the oxytocin infusion. If there's evidence of fetal distress, a bradycardia, or a fetal bradycardia or fetal tachycardia with molding, or sometimes even passage of meconium, you want to stop the oxytocin infusion. Then of course the appearance of an untold maternal symptoms, you want to actually stop the oxytocin infusion. I really hope you learned a lot on the use of oxytocin in labor ward, and this has shed more light on the calculation and the convergence of international units to mil international units. If you did, consider subscribing to the channel. My name is Dr. Moses Kazevu. Until next time, bye-bye.